Good evening, everyone, and welcome to the ASHA Virtual Town Hall on in-person service delivery considerations for speech-language pathologists in healthcare providing services during COVID-19. I'm Monica Sampson, Director of Healthcare Services and Speech-Language Pathology at ASHA, and I will be your moderator this evening. It is a pleasure and privilege to connect with you all tonight. Over the past couple of weeks, we've heard from thousands of you who took the time to express your concerns, challenges, opportunities, and successes. Thank you. Your input guides the work of ASHA staff, and we are grateful. As healthcare-based SLPs still providing services in person, you are all working in high-risk situations where you care for patients who are either suspected to have COVID-19, those under investigation, those who have had positive tests, or those who are at a high risk for contracting the virus and are asymptomatic at this point. I want to say you are doing an outstanding job to meet the emerging needs of patients and your communities, often in less than ideal situations, and as part of interprofessional teams. As fellow healthcare SLPs, my ASHA teammates Jamila Harley and Rebecca Politis and I are acutely aware of the issues that you are encountering on the front lines. Between the three of us, we have worked in all healthcare settings, and we are familiar with the challenges you face every day. Most importantly, we recognize the courage, strength, and resilience you display each day when you show up to care for your patients. To us, and to me personally, you are superheroes. And thank you for trusting ASHA as an organization to represent your issues and advocate on your behalf. Now, let's get started. To set the stage, I want to share some numbers with you. We have had almost 8,000 questions submitted via the registration form, over 350 individual emails and calls from ASHA members since the pandemic started, and probably hundreds of questions and comments that you will be submitting live during this event. We are unlikely to have the time to address each one of those, as you may expect. However, there are broad themes that have emerged from your communication, and we're going to take a few minutes to dwell on each of these issues. Some of the transitions between issues are going to feel abrupt, but I would do that to just keep us moving. On the slides, you will find email addresses of ASHA teams who can discuss your unique circumstances. Please take advantage of their expertise as needed. Also, please note that we're not going to discuss specific clinical protocols for dysphagia services on today's event. And that is intentional, mainly because we want to make sure we have the time to delve into those issues at a separate event. We are working with the leadership of Special Interest Group 13s, swallowing and swallowing disorders, and related leadership groups in dysphagia, including Dysphagia Research Society and the American Board of Swallowing and Swallowing Disorders, so that we could bring you another opportunity to discuss specific clinical protocols on a chat. And that chat will be held next Wednesday evening. So please be on the lookout for additional details related to that. I want to give a special shout out to my team. Those are the people who are working very hard behind the scenes to get this program going, and also have taken the time to individually respond to each of your emails. And they are subject matter experts. They connect with subject matter experts to provide the latest information we can offer to you. Now, I invite our panelists to introduce themselves, and then we can dive into the questions. Kim, could you get us started?
Yes, hello everyone, and good afternoon. Excuse me. I am Kim Delahanty, and I am an infection preventionist, clinical epidemiology nurse. I have done clinical epidemiology and infection prevention for over 25 years. I have worked in home health, hospice, home infusion, acute care, as well as a large academic medical center. For 16 years, I was the administrative director for the UC San Diego Health Infection Prevention and clinical epidemiology program. We have 5 hospital systems as well as over 200 outpatient facilities. We also were the #1 trauma center in Southern California and also had a burn center as well as a lot of other service lines. I am currently now working with Doctors Without Borders, or MSF, as their IPC, Infection Prevention and Control Manager. I have just returned from Bangladesh, being in a project there, working with the refugee camp, and am now currently, as of today, their headquarters IPC, which is Infection Prevention and Control reference/advisor for the New York City and Paris office. And I'm so happy to be here, and I hope that my information can help ease your burden. As Monica said, you are the unsung heroes on the front lines taking care of our patients, and I thank you.
Thanks, Kim. Donna?
Hi, everyone. My name is Donna Euben, and I'm the Director of Ethics at ASHA. And I'm not anywhere international. I'm here in the United States, and I've been doing professional ethics for the last 20 years for professors, lawyers, and now I'm honored to be doing SLPs and audiologists. And I just want to say, today, we're going to be talking about different ethical questions. I know that you're going to want definitive answers. And unfortunately, ethics is somewhat of a gray area, and there's always specific facts and circumstances. And of course, different state laws apply. So my goal today is to raise the red flags of different ethical considerations for you to think through, and sometimes to at least flag potential laws that might apply, but only our Board of Ethics can provide the final interpretation and guidance of our Code of Ethics. And we do not provide binding legal advice. We are providing legal information as well as general guidance on our Code of Ethics. So please don't get frustrated. We are also learning with you as this pandemic unfolds. And we look forward to working with you and learning from you. And you will notice that our ethics email address is posted on almost all the slides. And we really do, we are here to help you, and we hope that you'll take advantage of following up, since we won't be able to answer all the questions that you have today.
Thanks, Donna. Jeff?
Thank you, Monica. Good evening, everybody. My name is Jeff Regan. I have the privilege of serving as ASHA's Director of Government Affairs and Public Policy. I am not a clinician by background. My career has been in government as well as in advocacy. I spent a decade on Capitol Hill as a policy advisor to former Senator Christopher Dodd of Connecticut, and I spent about 6.5 years at the American Psychiatric Association working on mental health and substance use policy before joining ASHA in my present position about 3 years ago. On behalf of the 4 teams that I work with within the Government Affairs and Public Policy Cluster, that's the Healthcare Education Policy Team, the Federal and Political Affairs Team, the State Affairs Team, and the Advocacy Communications Team, I want to echo what my colleagues have said by thanking you and considering you our heroes in this effort. We have been working with many of you and many of your colleagues over these past 3 chaotic weeks, fielding technical assistance calls, providing policy guidance both on the federal level and on the state level where we can. We are really right now in a paradigmatic shift in the public policy landscape around healthcare delivery, especially with respect to licensure waivers and the practice of telehealth. This evening, I can give you some broad overview and broad perspective on a couple of, or several rather, principal topics in the area of government affairs and public policy. As Donna alluded to a couple of minutes ago, a lot of these issues, though, depend upon really where you live, because once we move out of the federal realm, there's a patchwork of state laws and regulations that govern a lot of these areas. So we have, for the past couple of weeks, developed a lot of very good and helpful resources on ASHA.org, as well as the special ASHA COVID-19 page. And so I encourage each of you, if you have additional questions, to visit that site to get more state-specific information, and certainly to reach out to our teams, because we are here for you, and we thank you for everything that you're doing. So thank you, Monica.
Thanks, Jeff. Kim, let's get started on the note of infection control and speech-language pathologists. So one of the questions we very commonly get is, what can I do to keep myself and my patients safe during the pandemic when we don't have access to, or we have very limited access to, personal protective equipment, which I'm going to keep referring to as PPE throughout this conversation?
Yes, great. Thank you, Monica. It's an excellent question that everyone in healthcare is struggling with during the pandemic. So basic common sense rules is always to cover your coughs and sneezes. Even if you don't have a mask, you can also do that within your sleeve. This is what we call doing it in your sleeve. So if you feel like you're going to cough or sneeze, that you're going to do that in your sleeve. That's going to protect you and others around you in the event that you might be carrying anything. We are not only infection prevention isn't only about COVID-19. This has just highlighted the process and procedures we need to take during a respiratory pandemic. You want to make sure that you are aware of your patient's conditions, asking them good history. Are they experiencing a fever? That's number one, especially in the pandemic. Do they have respiratory symptoms? Have they been around anyone with those symptoms, fever and cough, sneezes, runny eyes? Excuse me. And then also, have they had any travel? All of this is really key before you go into the setting that you're going into to take care of the patient. It's a complex situation because the speech pathology goes everywhere. It goes into their homes. You go into clinics. You're in the hospital setting. You're in private sector sometimes. And so as much as we want to make sure you're protected, it is contingent also on the employers of the facilities for which you're working to help with that education and with the supplies that you need to stay safe. I would say that if you feel uncomfortable, that you raise that up through the chain of command and ask for an answer. Ask for the leadership to let you know, what is the practice? What are we going to do in the event we don't have enough personal protective equipment in this situation?
So a really good question is when our clinicians are asked to go in and provide specifically dysphagia services or any other procedures which particularly result in production of aerosols. And when there is no access to PPE, or like we said, limited access to PPE, what are safeguards that you want to put in place? I know the CDC recommendation is to use an N95 mask, and those are definitely in short supply. So how far down the less than ideal can you go? Can you use surgical masks? Can you use homemade masks? And what precautions do we want to take for ourselves as clinicians, as well as for our patients?
Right. So those are really great questions, Monica. And like Jeff said, this is all, unfortunately, we don't have a federal mandate that we could say black and white, this is what everyone needs to do. It is state by state, unfortunately. And when we say state, we're talking about the state public health departments. They're in communication with the governor, who's in communication with the federal regulatory bodies. So on the line, boots on the ground, which is what you're all doing, is that currently in the state of California, and this is the only state I can speak to, they are removing the mandate for N95s except for aerosolizing producing procedures and using regular surgical masks for everything else. So you would wear an N95 only if you're doing bronchoscopy, if you were doing, swallowing tests. It actually promotes a cough sometimes, so we would consider that aerosolize generating procedure. Something is better than nothing in this situation. I don't want it to go back out that Kim Delahanty said, no matter what, even after the pandemic, we can wear bandanas around our faces. That is not what I'm saying. During a pandemic, it's a different rule set than it would be on a day-to-day standard procedure. So again, making sure that the people who you report to know there's a shortage. Now, I say that tongue in cheek, but sometimes people are in the weeds so much and you're assuming they know that you don't have the equipment that you need. So again, good communication, making sure that this is a priority procedure, that you have to absolutely, for the care of the patient and the safety of the patient, because that comes first, and the safety of you, that this is something that has to be done. Can we transfer this patient into a clinic setting or a hospital setting that has more availability of supplies, or has a secluded area, a room that maybe has negative pressure that's going to help decrease that exposure to the aerosolization? Again, wearing masks when you can. People are, some people have been wearing bandanas or scarves. That is not recommended for healthcare workers at this time, though. They are working diligently to try to get these masks to everybody, and the face shields. So remember, it's not just this part, it's the whole mucous membrane, and you need to make sure you're protecting your face, your eyes, your nose, your mouth. That is where the virus can get into. It's different than in bacteria. Bacteria can live on the body in all different areas. Viruses mainly need some place to live, and where they need to live or where they thrive is in your mucous membrane. So that's why this pandemic is such a focus point on this part of your body. And hand hygiene, staying 6 feet away. 6 feet away is, rule of thumb, double the arm length of yourself, and that's roughly 6 feet. It's not exact. Another way to do it is, if you can look at someone in your eye like this and see their full face, then you're about 6 feet away. Having the knowledge of what the patient is dealing with, what are they needing? Is this just a med check and a check to see that they're okay in the sense of activities of daily living? Or is this test actually going to be needed in order for the patient to survive, to breathe, to swallow, to talk, those types of things? Again, it's doing a risk assessment. We really need to make sure that we're doing a risk assessment in this day and age, in this pandemic, on the needs of our patients, especially those that are in home health, hospice, home infusion, long-term care, skilled nursing facilities, clinics. And again, looking to your local and state advisory. There are people working on this in the long-term care arena, in the home health arena, in the prison arena, where we're, everyone's focusing on the hospital, but what happens to all of the alternative care sites that we do take care of patients in? And there is no perfect answer, and I apologize for that. But again, just making sure you're communicating up and that they know that you don't have what you need.
Kim, it's a good point you raise about risk assessment. So what does a personal risk assessment or a patient risk assessment look like? I know you mentioned one of the points, which is, does this person actually require this service right now? Is it an emergent service that needs to be provided right now, or can it be deferred to a different time? Are there other considerations we want to put in place? And I see a couple questions that have come in that say, they highlight the fact that the potential of asymptomatic people possibly being carriers of the virus is pretty high. So recognizing that, should we then be wearing surgical masks or PPE in some form for all interactions within a healthcare setting or in the home? And one of our members says she's a person who's been spit and splashed on in the past week during oral care prior to even the evaluation. And being that we never know if a person has an infectious airborne disease, should we be using PPEs for everything?
So that's a great question. And I think if you've been following along with what the government is looking at, this is an ever evolving, changing. What I say today is probably going to be different tomorrow. They are looking at universal masking, but that in and of itself has its own challenges. If we all go to universal masking, then we are taking away from the healthcare arena who are the most important people who need masks. This is not something magical that we can put a different mask on a layperson and then another surgical mask on a healthcare worker. They're all the same mask. So we have to be very diligent in what we're thinking and what is the downstream effect. One of the risks of being a healthcare provider, unfortunately, is that, yes, we do expose ourselves unknowingly sometimes to things. And we have to do the best that we can about knowledge. Knowledge is key, knowing what it is that your patient potentially could have. In this, yes, you're correct. We have asymptomatic people who are actually, as the infectious disease specialists are saying, that they are actually transmitting, and that's why it is spreading so quickly. So risk assessment is independent of each person, and you're looking at that with, there should be some kind of bioethics committee within your organization. It could be just the CEO, yourself, and the director of the program who's sitting down and saying, here's our caseload. Here are the people that we're concerned with that need actual care right now, and these people, they can wait. And then you would have to develop a plan. What does that waiting mean? Every 3 days? I don't know the frequency of when you're going in and doing these types of procedures, but looking to see, can they be transferred to a facility where they can get this done, or can this wait? And I know we're going to talk about ethics later, and sometimes, unfortunately, in a pandemic such as this magnitude, which we've never seen except in 1918, and I don't think anybody's probably alive on the call, but if you are, congratulations. So we are dealing with this as we understand the virus as it evolves and keeping abreast of the information. The challenges with the care that you provide, as I said before, is that we have hospital-based, which that's usually dialed in pretty well. You have a program, you have a emergency response team. Everyone's looking at all the different type of patient populations and the services you provide. On the clinic side, usually that's the case, especially if it's tied into a hospital setting. But if it's an independent clinic, if it is owned by a single individual, unfortunately, pandemic is not the only concern that infection prevention has. A day-to-day basis on everybody within that healthcare facility needs to have infection prevention and control knowledge, personal protective equipment, and access to all of that, and using it correctly and removing it correctly. And so oftentimes with smaller mom and pop shops, if you will, for lack of a better term, they have to pick and choose where their money goes. They have to pick and choose what they're going to set up for. They may not even understand the process of infection prevention and control. And so that's what we're seeing now as these outlying areas are going, wait, we don't even have a stockpile. We never even considered this. We didn't look at this. It is challenging, and I really want you to know that people are really trying hard to figure it out. But being engaged as the frontline worker is really key so that they can get the big picture for what the needs are for you. Maybe you have plenty of masks, but you don't have the eye shield protection, or vice versa. There is also on the CDC website reuse and extension wear of masks that tells you how to do that, how to make face masks. People are making face shields. There are processes by which I can share with Monica that we can put on the website, but this should not be done in a silo. This should really be done at your organizational level. This should be brought up at the leadership level so that they're putting a process together. And I think this is where ASHA can help. I belong to APIC, which is the Association of Professionals in Infection Prevention and Control. And what we do on the front lines as IPs, infection preventionists, if we see something's not happening, if we know science-based evidence isn't happening, we bubble it up to them. They're a lobbying body, and they can help oftentimes put together processes, talk to the leadership, talk to the regulatory agencies, talk to the state and local health departments to say, this is what's happening on the front lines. How can we help? And I know it's not a cookie cutter answer, and it's not black and white, and I apologize, but that is what we're dealing with right now during this pandemic.
Thanks, Kim. Several questions about aerosolizing procedures and which procedures are aerosolizing procedures. And there is a question here on, is ASHA planning to publish a position statement regarding PPEs and aerosol generating procedures? And the answer is yes, and not just planning, but we actually have a statement on our website that went live this morning. It parallels some of the guidance that RCSLT, the Royal College, has put out for practice in UK. This statement that we have digs in a little bit more into the SLP scope of practice as is implemented within the United States. So definitely take a look at that and feel free to let us know if you have additional questions about it, and we'd be more than happy to clarify. There was one last question on the infection control piece before we shift gears. There's a question that says, what do we know about how long the virus survives on different surfaces? Is there a good resource we can direct members to where they can get that piece of information? I have seen different time spans listed in different sources and in the media, but is there an official scientific spot we can direct members to get that information, Kim?
Yes, so remember, this is evolving. This is evolving virus that we don't know how it's going to act. Are we going to have a second wave? We don't know, right? So, and people want answers, and I understand that. And I think the infectious disease and the health care providers understand that as well. So basically, there was one article that was put out, the Harvard Review, that suggested that it could live on surfaces. I don't think we know the exact answer. The CDC says also, Centers for Disease Control and Prevention, that it could linger on surfaces, but that is not the concern for the transmission. Lots of things can linger on surfaces, but that doesn't make them pathogenic. So again, it's that testing and knowing more about the virus. If you have a large secretion on your bedside table and you as the provider stick your hand on that, and then you touch your face, yes, it's going to transmit. But the main transmission is aerosolization, is in the air, it's droplet. What I mean by that is it comes out of a body, depending on how big the girth of the patient is and how strong the sneeze, cough, laugh, talk, or whatever it is, it comes out 80 miles an hour, 60 to 80 miles an hour. There's studies that have shown this. And it usually comes out 3 to 6 feet. That's why we give that. It's a droplet, so it drops. If there's nothing there for it to attach to, remember, viruses need mucous membranes, this part of your body. If it's nothing there for it to attach to, it drops. That's why it's called droplet. And it will die. It's very fragile, very fragile. If we thought that this was a contact transmission versus droplet, then all of our cell phones, we would have huge more numbers than we're seeing now in regards to transmission. So that is something that's evolving. Yes, there's some indication that it could linger on some surfaces for 3 days. It might linger on, depending on metal, it could be 30 seconds. Again, it's related to, is there a biofilm or are there secretions there that are active and live, and then a person touches it and then touches their face. So there's a lot of variables around that piece, but that's going to be evolving.
Great, thanks for that.
Could I just answer one question that I saw about the N95s?
Sure.
I think this is key. N95s should be single-time use if we're not in the time of a pandemic. So again, everything you're learning now, you're going to have to change your mindset once the pandemic is over. N95s are single-use, not during a pandemic. During a pandemic, they can be reused as long as they're not crushed, wet, punctured, and usually 1 week is about what we say to use. There's also some documentation out there about extended wear and reuse of these masks, which I will give to Monica and they can put up on their website.
Thanks, Kim.
Thank you.
We're shifting gears a little bit here and moving into the world of our labor classifications, if you will. We have had a ton of questions that have asked us if SLPs are essential workers. or are they classified as non-essential workers? And these are questions that have come in during this event on the registration form. It's a huge chunk of what we've been responding to. A couple of our panelists can speak to this. I'm going to ask Jeff to kick it off and then have Donna chime in as well, if that's okay. So fundamental question here, Jeff. Are speech language pathologists considered essential workers?
So the answer, unfortunately, is it depends. It can be yes or no. So there has been federal guidance issued by the Department of Homeland Security's Critical Infrastructure Security Agency that explicitly lists SLPs as caregivers under essential personnel. However, it's important to note that this is guidance. This is not a directive, and it's guidance for other entities that do apply the designation of essential. And those other entities could be state governments, especially during times of emergency. It could be an employer, or it could be an employee union. So generally, the designation of whether or not an SLP is essential is usually a local entity, certainly following the guidance that's been issued by the federal government. But again, the federal government's guidance is not a directive. Ideally, and this is an important point to make, managers and employers should be communicating with the staff that they have designated as essential regarding job expectations, regarding work assignments, and other relative operational contingencies during the time of emergency. One thing that we have communicated to members over the last couple of weeks is some helpful guidance that the American Healthcare Association and NCAL released a couple of weeks ago on the role of PT, OT, and speech in long-term care facilities and SNFs during the pandemic. This statement offers guidance on assessment and service delivery in an effort to restrict entry of as many people as possible into these facilities while ensuring that the essential needs of individual patients are met. For ASHA, we can't designate the employment classification of SLPs as essential or non-essential. However, what we have been doing over the past couple of weeks, and what we will continue to do going forward, is to engage employers as well as other oversight bodies on behalf of our members to ensure that the value of SLP services are clarified, as well as to ensure that the health and safety of SLPs are fundamentally protected. So that's a kind of a brief overview, or an answer, as brief as I could make it, to the question, are SLPs essential workers? Donna, do you have anything additional to add with respect to the ethical implications?
Not really in terms of the ethical implications, but just to follow up on your comments, Jeff, that in terms of most states do designate who is essential and who is not essential, and really the emergency will vary, and with the emergency, who is essential and who is not essential will vary. So if it's a pandemic, it could be healthcare providers. If it's a snowstorm, it could be truck drivers. So it does vary, and usually it will say essential employees, and it will say usually include, and it'll say not essential, but sometimes it'll say occasionally non-essential employees will also be called. So, and many employers should do annual kind of updates or disclosures and review what the expectations are of essential and non-essential employees. So that's just following up on, Jeff, your point in terms of the state guidance that's put out.
Thank you. So a related topic, and Jeff, maybe you can take this again. I'm not picking on you at all. So a question that we've been asked a lot is around hazard pay, and do SLPs get them, or do SLPs qualify for them? And also, what do we have to do to get them, considering we are on the front lines of service delivery, and if we are being classified as essential workers, shouldn't be getting paid extra to assume that risk?
Yep. Well, Monica, that's a very good question. And it's a very understandable question during this period of time. I can give you what the current policy landscape is right now with respect to this topic and where I think it may be going over the next couple of weeks. So currently, there is no federal or state policy in place that mandates hazard pay for SLPs who are designated as essential personnel. Again, whether that designation comes at the state level, whether that designation is made by an employer or an employee union. However, I can say, and this is very late breaking over the last 24 to 48 hours, there have been some discussions underway in Congress about addressing hazard pay in a fourth coronavirus response bill that's currently under consideration. We'll probably talk a little bit later about the CARES Act, which was enacted into the law at the end of last week. That was the third response package that Congress has passed related to the pandemic. A fourth package is underway, and Senator Sherrod Brown of Ohio and others have been pushing the proposal for providing hazard pay to essential personnel on the front lines. Right now, this policy is nascent. We are going to be engaging Senator Brown and other relevant parties going forth to get more information. Obviously, we want to do everything we can at ASHA to support our members who are providing services on the front line. And certainly, this is a policy that we will take into close consideration as it develops going forward.
Thanks, Jeff. And a related question, which I'll let anybody take actually, is how do you make a case, how do you sort of balance this? On one hand, as SLPs, when we create plans of care, we're providing justifications for medical necessity of services. And on the other hand, if we're asking for classification as non-essential services, especially, we've had some members say, if I'm having an outpatient clinic or a private practice that's all language or cognition, which may not be an emergent service at this point in time, how can you balance the two? On one hand, you are making a case for it being medically necessary services. And then on the other hand, you have the issue of, well, shouldn't we be non-essential to reduce the risk of transmission of disease?
Monica, I can provide an answer if you'd like, or Donna, if you have an answer, that's fine.
No, that's fine, Jeff.
Okay, so this is actually a very good question. It's one that I've had some discussions with some of my colleagues in government affairs around. And when we're in the middle of a public health emergency, I would suggest that there is a difference between what meets the standard of medical necessity as it relates to programmatic requirements for coverage and reimbursement, and what meets the standard of essential services, because the two are quite distinct. I think we probably all know medical necessity is the standard baseline of coverage, depending upon an individual's clinical needs. Essential care, though, would be a subset of that care, and it represents a higher need than the baseline standard of coverage. Unfortunately, during this time and in general, we really have no uniform standard established for an SLP to make the determination of what services clearly meet medical necessity standards, but are not necessarily essential within the context of the emergency period. And so that's why we have been and continue to give technical assistance around the fact that those determinations have to be made on an individualized basis based on the individualized need of the patient. And in a similar way, there is also no standard broadly for applying the risk and benefit of any service delivery between the patient and clinician. So again, a clinically informed determination must be made on an individualized basis. So that's right now the best information, that's the best guidance that we can provide in this area. But to note, there is that differentiation between what meets the standard of medical necessity and then what meets the standard of essential services.
Thanks, Jeff. And Donna, I'm going to toss a question to you that piggybacks off what Jeff said. and I'm going to read it verbatim. So the member asks, if an employer, does an employer have the ability to terminate an employee if that employee does not report for duty unrelated to the employee's job description? For instance, if I am called to the hospital to transport patients positive for COVID-19, but I refuse due to my own health concerns, does the hospital have grounds to terminate my employment? And I'll give a little bit of background to that. The slide has this bullet on multi-skilling, which is a concept that's not new in healthcare, where you may be asked to do duties that are outside of your scope of practice, but fall within sort of generic job responsibilities. Taking vitals, for example, or suctioning is another one that we often discuss in the context of multi-skilling. But we also recognize that there are some state executive orders, and I'm familiar with the one in Maryland that my licensing board shared with me, that explicitly said that all licensed healthcare workers can provide services outside of their scope, specifically during this pandemic, in order to keep up staffing levels, to keep up operations within the healthcare facility. So it brings the whole notion of competency in a very different light. And considering the risk there in engaging in procedures, and the risk may actually be higher than the typical risk assumed by an SLP, to come back to this member's question, can SLPs refuse to provide those services, and can an employer fire you for that?
So you're saying if an SLP is being asked to do something that they are not trained to do, or not to meet the pandemic's need?
Exactly. It's to meet the pandemic's need for organizational efficiency, and not so much, well, I'm going to go in and do an endoscopic procedure. Not quite that.
Right.
Just general care.
No, I mean, this is a question that has come up from a lot of colleagues in this context and other contexts. And I'm looking at the Code of Ethics, the 2016 Code of Ethics that applies to SLPs, where we do say it is the obligation of SLPs to be competent in the services they deliver. And we're all very conscious and aware of wanting to be competent, and knowing that our clients deserve our competency, and yet the employers are asking in this pandemic situation for us to be moving quickly and assuming responsibilities that we haven't necessarily been trained for. So it is an issue under our Code of Ethics. We have been trying to suggest practical suggestions in terms of asking the employer if there are ways to be trained to do particular tasks that are being asked, if there's ways to shadow someone who's already doing that task so that the person can become more familiar with it. But this is where ethics comes into real tension and what's going on in real life when people are being employers are making demands of them in the workplace immediately for skills that they haven't been trained in. I am not anyone's lawyer, so I can't necessarily say if someone can be terminated for it. I think if an employee asks for ways to be trained to ensure that that they are competent and are delivering the skills, delivering the services competently, that will be in the interest of the employer as well in terms of malpractice and liability insurance. And so I think that there's a way to work with an employer to ensure that the services are delivered in a competent way.
Thanks for that. And now switching into providing services that are within the scope of practice, that within the SLP scope of practice, but that place you at a higher risk, especially when the facility is not giving you PPE, and they don't want you to bring your own PPE either. And I have a member who's asked a two-part question: who designates SLPs as essential and non-essential workers? And if I understand your responses correctly, it's based on the guidance from the federal government, but the designation comes from state entities and
employers,
organization. Yeah. And so the member continues to say that she works in an outpatient setting and she's given one surgical mask a day and no N95 masks, and they're not allowed to bring their own PPE. And actually, we've heard that from members in other settings where they say even when they have PPE, employers advise their clinicians to not wear them because it might frighten the patients. It's a question of dignity. We've heard all of those reasons. But in this case, can the SLP say, no, the risk is too great and I just refuse to provide services, no PPE, no services? Is that a viable route to take?
I think looking at the Code of Ethics, the overall prism to look through it is that we want to honor our responsibility and hold paramount the welfare of the persons we serve. And the persons we serve professionally are going to be protected by us wearing our protective gear. So it's both for our own safety, but it's also for the welfare of our clients in case we're asymptomatic and or carriers in some way. So it seems to me that it would be an important conversation to have an SLP with the employer to figure out how to best protect the SLP so that she or he can deliver services effectively. I mean, you have to protect your client. You have to protect your own health and safety. And in fact, we say specifically in terms of client abandonment that you can stop treating clients if your own physical safety is in danger. So arguably, if your physical safety is in danger, especially if you're one of the three categories where the COVID-19, you're specifically vulnerable. I think it's the over age 65, pregnant and breastfeeding, or the immunocompromised folks. I think you could make a very strong argument that you're not going to be able to deliver services because without the PPE, the employer is putting you in physical danger as well as compromising the welfare of your clients.
Mm-hmm. A related question, and again, either Kim or Donna can jump in. And Kim alluded to this earlier. It's the bioethics of prioritizing patient care. How do you look a patient in the eye and say, to me, your deficits are not important enough for service delivery right now? Well, to another patient, you say, no, you somehow make the cut. It's a hard conversation to have with patients and caregivers, especially when there are deficits that don't rise to the level of emergent care, in the sense of if the patient's not at risk for nutrition or hydration issues. But consider a patient who's post-stroke, an acute phase of recovery, right? And here, my goal is to capitalize on that spontaneous recovery period, especially in the first 3 months. And now, if I'm being told I can't treat this patient because they have a language deficit and they're not at risk for a swallowing issue, how do I reconcile that? Where is there a decision matrix we can use to think this through?
I'm going to let Kim at least take the first stab at that question.
That's a tough one. Yes, and I think it is paramount that the organization has some type of emergency response committee team that is looking at that, and bioethics should be on that team. It's hard when it's an independent contractor or someone who is consulting and works on their own, because they don't have that periphery of references and resources to look at. I think this would be a great aspiration for ASHA, if they don't already have something like this, to put together some type of a template. It's not going to work for everyone, so you just do a basic outline of these are the things to consider in a situation like this. I think we're going to be learning a lot of things, and we're going to be changing our practices after this pandemic is over and the recovery phase starts. And I think we're all professionals, and we all have to do what we feel is professionally prudent. What would a prudent person do in this situation? And if you're in the emergency room department, you see this all the time. The triage that occurs is what we're talking about. And it is difficult. It is disturbing at times. However, if the patient is going to recover, but not at the pace that they normally would if you were able to go right in there, but your safety is at risk, and the safety of those other patients that you're then going to go see because they really need to be seen, we have to outweigh the risk benefit there. And it's difficult, but it is not business as usual. And so we really have to put together strategies and committees with the bioethics team and the leadership of the organization, with your state and local public health advisement, to say, what are we going to do in these situations?
Thanks, Kim. Donna, do you have something to add to that?
I mean, most organizations have bioethics committees that do have guidance and priorities, and do provide decision-making matrices to their staff and work through it. And I think what's important is to have those difficult conversations with your clients, because I think that's an obligation, an ethical obligation we owe our clients in terms of maintaining our client-provider relationship.
Thanks for that. And there's a comment that helps inform this situation that I just tossed out. There's a member who says, can't the service still be essential? For example, language therapy for a patient with new onset aphasia is still essential, but the risk regarding the virus can be reduced by changing the service delivery method from to telepractice. So that is a viable option.
Yes, sure. If there are other delivery options, service delivery options, absolutely.
Right.
Yeah.
The mention of telepractice brings up a point around how viable it is in different settings. We have practitioners in rural areas whose patients honestly do not have internet connections at home, or you have patients living in skilled nursing, long-term care, and they don't have internet connections in patients' rooms to make this a viable service delivery option. So yes, telepractice is definitely a viable service delivery model, but there are considerations for whom it may be appropriate. You often need an extender on the other end who can help facilitate the treatment. So yes, there are things to consider, but alternate service delivery models are absolutely appropriate and recommended during this time.
And if I could just contribute to the conversation, under the Code of Ethics, telepractice is an option in terms of a delivery method. The only thing that's limited is that telepractice by correspondence only is not embraced. That to provide the services via telepractice needs to be consistent with the professional standards and state and federal regulations. So again, going back to the point that both Jeff and Kim made, it is a patchwork, and every state has different telepractice laws, or some don't have any telepractice laws. And now some states are adopting different temporary provisions during the pandemic to allow to enact different or allow different telepractice laws. So you need to make sure you comport with all of that. And then, of course, you would need to make sure that delivering the services remotely is what you think in your professional judgment is the best way to deliver services to that particular client.
Thanks, Donna. I have another question that I'm going to read off the list here. And I know that you have definitely responded to this in your member communications, Donna. So the member asks, how should we proceed if a resident exhibits clinical symptoms suggestive of COVID-19 and the facility will not test the resident nor initiate contact droplet precautions? How should we proceed with treating if we're not provided with the proper PPE? And a related question that someone else has submitted is, if I refuse to continue face-to-face treatments for these patients due to heightened risk of disease transmission for me and or my patients, is that client abandonment? So
that is, you've asked so many questions that raise so many different ethical concerns and considerations. So at least let's start with the last issue first. And we touched on this briefly in terms of client abandonment. Under the Code of Ethics, Principle 1, Rule T, the rule specifically says individuals shall provide reasonable notice and information about alternatives for obtaining care in the event that they can no longer provide professional services. And that statement has been interpreted to mean that no clinician is ever ethically required to work in physical danger in order to offer client care. And so here, I think you would look to the CDC guidance, which speaks to the categories of employees who may be temporarily excluded from direct patient responsibilities for those who are suspected or known to be positive COVID-19 patients, which goes to the pregnant women who are breastfeeding, immunocompromised employees, and employees 65 and older. And if an employee falls into one of those categories, those temporarily excluded categories, I think there's a very strong argument under the Code of Ethics to say that you're not going to be abandoning your client, but that you cannot provide those services because it puts you in physical danger. Now, it doesn't mean that the hospital can't still direct you to perform patient care responsibilities for other patients or alternative duties, but it would take you away from being exposed from those who are either sick or have been exposed themselves. And also, in terms of client abandonment, you still need to make reasonable efforts to make sure your client is going to be provided the care and that there's a smooth transition of some kind. And if that isn't feasible, to figure out other ways to develop services. So as the person suggested before, if there's a way to protect yourself without wearing equipment such as remote services or telepractice, and you think that that's professionally appropriate, that's one way to deliver services if you don't have PPE. But if that's not an appropriate way and you don't have PPE and you will be put into physical danger given your particular health condition or status, then you talk to your employer and you say, we need to figure out a transition plan for someone else to treat my clients because I'm unable to, given my particular status during this pandemic.
Thanks for that, Donna. I'm trying to read.
And I don't know, Kim, if you have anything else to add to that.
No, I would totally concur with that. I think that the handoff, the transition, and documentation of everything in the chart in a notebook for yourself in the event that you're worried that this might come back afterwards.
Yes.
But that communication is really key, and doing a very strong handoff with someone who is willing to take that patient.
Thanks. On a different but still related to ethics is a question that says, I'm at risk for transmitting the disease to my patients by going from site to site, as in case of some of our skilled nursing facility members or members in skilled nursing facilities, or from home to home in home health and early intervention. How can this be ethical? Knowing that I'm actually increasing the risk for my patients by continuing to provide services. And if I don't provide services, my business or my employer cannot sustain the business to keep me employed. How do you suggest we think through that?
This is where it's more practical in terms of trying to, seeing if you can get PPE, seeing if you could deliver those services remotely, figuring out ways to protect your clients and yourself in that situation. It's a really hard and difficult situation, and we're getting a lot of calls about it. And this goes back to the CDC recommendation where folks should have PPE, and employers should be providing it to their employees.
And go ahead.
Well, no, I'm just going to say, and being unprotected is, poses a risk to the individual and to the client, and that's not putting the client's welfare, not keeping the client's welfare paramount. So it really raises significant ethical considerations. So the answer is PPE for all.
Yeah, I would agree with that. I would. There's some mitigation things that you might be able to do, like, for instance, section off that you're going to only go to this one skilled nursing facility or these 3 skilled nursing facilities. You're only going to do home health in this section of the city. That way, we are containing it as best we can in a situation where we may not have exact PPE. Also remembering it. Sometimes, we're touchy-feely, we're healthcare. We love our patients. We want to be there for them. But it is a 6-foot rule, social distancing, physical distancing. You may be able to do some of the care and provide the care, maybe by having the patient in their room and you sit outside the doorway. I know that there's a lot of other procedural things that have to happen that's hands-on, and that's not what I'm talking about. But we have to rethink how we do medicine. And in this time, right, in this pandemic, in this emergency, and this will not go on forever, and we will go back to the way we did things, and we'll improve on some of the things that we didn't do so well. But again, maybe sectioning off where you can go. You're going to go to skilled nursing facility 1, 2, and 3. And you do this in collaboration with your leadership, with your colleagues, with your state and local health departments if you have access to them. That way, okay, nurse A has gone to speech pathologist A has gone to X, Y, and Z, and speech pathologist B has gone to ABC. And it is just a way to try and mitigate the issue.
That's really helpful to know. I did try, I have spoken to folks about the 6-foot rule, and when they were talking about the kinds of services they were delivering, it didn't seem like that would work. But the sectioning off is a really good idea, and we're going to remember that for next time. Thank you.
Sure. It is not airborne. Let me just make sure it's not airborne. So if you are in a room and you are 6 feet or further away, there is no risk. That's why hand hygiene, wiping down the surfaces, and staying that physical distance is really key. Yeah.
Thank you. And I just saw the clock and I realized I need to
sorry.
keep moving along. No worries. But I'm going to shift gears a little bit to move into the advocacy world. So, Jeff, on to you. A question that's come up a lot, and especially in the context of alternate modes of service delivery, is the viability of telepractice in healthcare. And I'm going to roll a lot of questions into one when I ask, what does coverage and reimbursement look like for telepractice, specifically in the healthcare realm?
Sure. Well, thank you, Monica. And as I alluded to earlier, we're seeing a lot of paradigmatic shifts in healthcare policy right now, and that is happening the most with respect to telehealth and telepractice, specifically for speech-language pathology. Right now, it's a bit of a patchwork in terms of where things are with respect to coverage of telehealth services. So what I'll do is probably start with Medicare and then move on to talk about what we're seeing in the Medicaid world, what we're seeing in private health plans, as well as TRICARE. The theme is generally Medicare is the payer that leads the policy path, so to speak, and is usually the driver for change when it comes to healthcare policy, coverage issues, reimbursement issues, et cetera. What we've actually seen over the last 2 weeks has been a complete reversal of that. We have seen private payers, we have seen state Medicaid programs lead the change in telehealth coverage, and Medicare is playing catch up. So I should also preface my remarks by saying when we're talking about telepractice coverage, fundamentally, this is an option for SLPs to consider when providing services to their patients. ASHA is not saying you have to provide telepractice or you have to utilize teletherapy or telehealth. This is an option that we are trying to get more and more payers to allow our members to use. So currently, first, Medicare. Statutorily, speech-language pathologists remain excluded from providing telehealth services to Medicare beneficiaries, and that's simply because of our statutory definition under Medicare. We are defined as suppliers, and suppliers, by definition, are not authorized to provide telepractice to Medicare beneficiaries. What we're seeing, though, is a bit of a change in that. So over the past couple of weeks, when Congress was working on the CARES Act, that legislation I talked about a few minutes ago, we worked to try to get, and successfully, a provision within that bill, and that was enacted into law last week, that would grant the Secretary of Health and Human Services a waiver authority to essentially suspend the Medicare definition and provide expanded emergency coverage for telehealth services to professions that have been statutorily excluded to date. It did not explicitly mandate the Secretary to include our profession, but it was written as such that CMS does have the statutory authority to do so. So we are currently engaged right now in advocacy with the Centers for Medicare and Medicaid Services, working collaboratively with occupational therapists and physical therapists to persuade CMS to grant us emergency authority to provide telepractice to Medicare beneficiaries. Right now, I am guardedly optimistic that we will be successful. Please do not hold me to that because we don't know what the outcome is. But when I say I'm guardedly optimistic, I'm looking at what other payers have done over these past couple of weeks in terms of expanding coverage to telehealth coverage to our professions. First is state Medicaid programs. We nearly have 40 now state Medicaid programs that allows speech-language pathologists to provide telehealth services to Medicaid beneficiaries. And almost more notably, over the past week and a half, we've seen major private health plans announce decisions to expand coverage mandates for telehealth to include speech-language pathology. Late last week, United Healthcare announced a nationwide coverage plan. Cigna has announced a nationwide coverage plan. Several other payers have announced an intention to expand their coverage mandates to include our profession, and also TRICARE. So we have over 100 million Americans now with private health insurance. Those insurance mandates have changed, and those insurance plans now cover telehealth. Furthermore, it's important to note that Medicare Advantage has also provided expanded flexibility and demonstrated implementation for the use of telepractice. So again, the whole landscape has changed in an unbelievable way over the last 2 weeks. It continues to change. And again, I'm guardedly optimistic when it comes to conventional Medicare. We'll have to wait and see. But that's sort of right now an overarching view of where we are in terms of telepractice policy and reimbursement.
Thanks, Jeff. And a quick question to clarify. So when you say that a lot of payers have expanded coverage for telepractice, is that specific to the pandemic, or is that post-pandemic world as well?
It's a mix. Right now, it's for some it's emergency, for some it's permanent. And what we have online is a tracker, which you can access on ASHA's COVID-19 page, that's keeping track of all of the coverage mandate decisions that have been made by private payers. So you can go and check that resource. It's updated daily, and it keeps track of who is making what decisions, the nature of those decisions, and how extensive they are.
And that answers a question a member posed, which is, where do we find our state's guidelines regarding telepractice and procedure codes and reimbursement guidelines? And the answer to that is the ASHA COVID-19 page. You literally cannot miss it, because if you go to the main ASHA website, it's right there, right on top. Yeah. And there are several different categories of information, but there is a section specifically devoted to telepractice, which also includes billing and reimbursement.
And Monica, if I could just very quickly just add that on that telepractice page, we are keeping track of state changes. So mandate coverage changes that states make. There's a separate policy tracker for that. There's a policy tracker that keeps track specifically of state Medicaid programs, and then also the private payers. So all of that information is available to our membership. It's updated daily, and it's designed for you to go in quickly to find the state that you're interested in, to get a quick sense of what the current reimbursement policy is where you are.
Another question related to telepractice that I think is worth clarifying at this juncture is a member says, didn't CMS just approve SLPs to provide telehealth in private practice settings? I think that came out on Monday. And I know there's been a bit of confusion amongst PTs, OTs, and SLPs with regard to the CMS guidance that came out. Could you provide some additional clarification about that, Jeff?
So this, and Monica, if you could just repeat again what the question was.
The CMS regs that came out that included PT, OT, and SLP codes as covered, but it didn't necessarily lift the restrictions for PTs, OTs, and SLPs to actually provide that service.
That's correct. So there is a distinction. Again, it goes back to the statutory definition under Medicare. That is what is prohibiting our profession, along with PTs and OTs, from right now providing telepractice to Medicare beneficiaries. There was some CMS guidance around codes that could be used. And Monica, are you referring to the e-visit codes? I'm still not 100% sure.
No, not the e-visit codes, but the guidance that came out on Monday.
Oh,
Wednesday.
thank you.
Yeah.
Okay,
Monday, that gave us just the permission, that gave current providers the permission to use those codes, but didn't include us as providers who can use those codes.
Yes. And so the codes, the fundamental thing is that we are still not eligible providers under Medicare. That's what the most important point is to mention right now. And then until CMS changes the statutory definition to include our members, we cannot provide telepractice under any codes. So there are some codes that physicians use, And so I think, Monica, that might be what you're getting at. The codes that were announced are also codes that physicians can use to bill services. And physicians, by definition, can provide services via telemedicine. So again, it goes back to the fact that we are not defined as eligible providers under Medicare currently to provide telehealth.
And when you talk about expansion of coverage by payers, is that both inpatient and outpatient billing?
It is, yes.
Thanks. Shifting gears from telepractice, how is ASHA advocating for small businesses and independent contractors? And we get this question a lot from members who work as independent contractors in a lot of different settings who often don't have the same protections as salaried employees. And also from specific to the healthcare world, we have a lot of providers who own mobile fees or mobile video fluoroscopy businesses and are significantly impacted in how much and what they can do. So how is ASHA advocating for small businesses and independent contractors?
That's a great question, Monica. It is not lost on ASHA in terms of the number of members that we have who do own small businesses, who do serve as independent contractors. So I go back to the legislation that was passed by Congress last Friday, the CARES Act, and ASHA was pleased to announce that the CARES Act provided a number of provisions to help small businesses and independent contractors that were impacted by the COVID-19 pandemic. So these provisions include, among other things, a $350 billion Paycheck Protection Program. It's a program that's in effect through the end of June of this year. It provides eligible small businesses with government-backed interruption loans, which could then be forgiven based on the borrower ensuring that it can keep its employees on payroll. In addition to the Paycheck Protection Program, the CARES Act has provided relief to small businesses through the Small Business Administration's Economic Injury and Disaster Loan Program. Traditionally, that is a loan initiative that it kicks into gear during times of national emergency. That program has been expanded to include not only just traditional loans, but also emergency grants up to $10,000 for eligible businesses that have been impacted by the pandemic. These changes, again, will run through the end of this year. And then the CARES Act also has a number of tax credits, which will be in effect for this year. Tax credits with respect to employee retention, as well as the delay of payroll taxes, modification of net operating losses, modification on limitation of losses for sole proprietors and pass-throughs, a number of credits that are designed to assist small businesses during this difficult time. We just this week put on our ASHA COVID-19 page a reference tool that talks about these programs in much greater detail. These programs are designed for small businesses. So for any business that has 500 or fewer employees that can demonstrate an impact from the pandemic is eligible for consideration. We do have additional information and additional guidance on our COVID-19 page. And as information comes out from the Small Business Administration, as information comes out from the administration in the coming days and weeks, we will make sure that this information is updated for our small business owners. Because certainly we talk a lot about the healthcare impact, we talk about healthcare policy, but the small business component, the private practice component, the suffering that our members are currently enduring because of the economic fallout from the pandemic is certainly forefront on our minds as well.
Thanks, Jeff. A question that's come in is there something SLPs can do to expedite advocacy for Medicare telepractice reimbursement? And I'll extend that question and say, what can SLPs do to partner with ASHA as an organization to move the needle on a lot of these issues? I'm talking telepractice, I'm talking access to PPEs. What does grassroots advocacy from SLPs look like for these?
So that's a great question, Monica. In terms of our grassroots advocacy, there is an opportunity for members to take action right now to weigh in with Congress about the importance of expanding Medicare telepractice coverage to speech-language pathologists. And then I also encourage each of you to share your narrative and to share your perspective with us through reimbursement at ASHA.org in particular. If you do wish to provide telepractice, if you've been providing telepractice already, if you have a narrative, if you have an experience to share with us, I encourage you to do that because those narratives, those perspectives provide so much additional value and provide so much additional strength when we engage CMS on your behalf to ask for the emergency expansion of Medicare telepractice. So that's my response for tonight, is to stay tuned and to visit our Take Action site where you can take action now, as well as to be on the lookout for additional action alerts as we post them, depending upon how events unfold in the coming couple of weeks.
Thanks, Jeff. In the last couple of minutes, I'm going to shift gears a little bit, and we're not going to delve too deeply into issues of dysphagia care and COVID-19, specifically because, like I said in the introduction, we're working with SIG-13, swallowing and swallowing disorders, to provide you another opportunity to engage on the clinical issues. But I do want to highlight some of the issues that are on our radar, specific to dysphagia, and I'll broaden it out to say clinical care in face of COVID-19. A question we've been receiving a lot is around instrumental assessments of swallowing for patients who have been identified as being COVID positive, and also those who are under investigation. And as one member's comment came in that just said, basically at this point, everybody is presumed COVID positive and provide services in that way. So there are a lot of considerations there. And CMS's guidelines have basically indicated they tag team with CDC guidelines, which say if it is not an emergent service, stay away from it. If it's primarily because of the risk of infection spread, and the concern around aerosol generating procedures (AGPs) is particularly important. And you'll notice in the guidance ASHA created and posted this morning that we agree that a lot of what SLPs do falls within the realm of AGPs. It is everything from oral mech exams to clinical bedside assessments, the way it is defined as anything that can trigger a cough, right? So, which is a majority of what we do in the realm of swallowing or voice. And it could be even that you're working on cognition with someone with a diagnosis of dementia, and you're still at high risk of being exposed to it because the patient may be a carrier. So our guidance has been that during this pandemic, take extra precautions, specifically as CDC suggests. ASHA does not have additional infection protection guidelines because we defer to the expertise of groups like CDC. So all that to say, we agree that you need the protection. We're lobbying hard with your employers. At every opportunity that we've had to communicate with employers and organizations and governing bodies, we stress the importance of what SLPs are doing and why they need access to PPE. Another question that comes in pretty frequently are, what are standards of practice during this pandemic? Knowing that having instrumental assessments is prior to creating a plan of care for patients with dysphagia is the ideal. And knowing that you don't have access to those, what exactly does standard of care look like during the pandemic? Or what are extubation protocols for these patients? What is long-term impact on cognition? What is SLP's role in delirium to address them? What do our services for patients on trachs and vents look like during this pandemic? These are great questions. The short answer to that are there are no established protocols. Every organization is looking at it differently and interpreting it differently and prioritizing care differently based on the availability of PPE and who gets access to it. That said, a lot of this is what is going to be discussed in the SIG13 chat. We also have courses on the ASHA Learning Pass that talk about managing medically complex patients and talk about providing care to patients who have trachs and are on mechanical ventilation. So I encourage you to go check those out, and they form good foundations. Now, not all of those can be implemented during a pandemic, but they give you great starting points to think about care for these patients. And I also want to highlight a series of courses that are being offered by our friends over at Passy Muir. And a lot of you in the healthcare settings know that they have offered some good education in the past, and they continue to do that. And they are specifically talking about extubation protocols for COVID-19 patients. And that's coming up over the next couple of days. So go onto their website to check it out. And so there are other opportunities for education that are being provided to meet these needs. They're just not being addressed here. And I don't want it to seem like we're not touching on it, because we will be digging into it, and those are larger questions, and I don't want it to be a 10-minute discussion. So just wanted to put that out there. And I know that we're almost at time. So with 3 minutes to go, do the panelists have any concluding remarks? And Kim, why don't you go first?
Okay, so hopefully this was helpful. Unfortunately, as we all stated, this is a moving target and don't have all the answers for you, but there are people out there working on them and wanting to get you the answers and get you the personal protective equipment. I would just leave you with this comment, is that regardless of a pandemic, as it relates to infection prevention, the word prevention is key. And we all have to do our part, and you're all wonderful heroes on the front lines doing what you need to do, but you also have to protect yourself. And so hand hygiene, wearing personal protective equipment, not when we're just in a pandemic, but any time that you are potentially going to be exposed to blood or body fluids, we really should be wearing our masks and our face shields. And I understand there were some comments in relationship to it demoralizes the patient, it makes them feel isolated. However, we have to think about things that we don't know. We did not know about this coronavirus. There's a lot of organisms that are still continuing to be transmitted during the pandemic. So it's not just about this one isolated pandemic. It's about protecting yourself as a healthcare provider and making sure that you understand what infection prevention is. If you do not have a new employee orientation that is associated with infection prevention, that would be one of the things that I would ask you send up the chain of command, that it is a requirement by OSHA that everyone gets that training, and then annually. And that is something we need to make sure that we're doing all the time, not just during a pandemic. Thank you.
Donna?
I want to first thank you all for what you do every day, especially during the pandemic, and for making time to participate tonight. And I also wanted to make sure you know that the ethics unit is here for you and to service you. So please take advantage of the email address if we can be of assistance, if we can consult. We are here and we want to support you in any way we can. Thank you.
And Jeff?
Well, just like Donna, I want to thank you all each and every day for what you do and for the impact that you have on your patients. It's a privilege to work for you. It's a privilege to fight for you. And government affairs and public policy, we are here for you, and we will continue to work with you. We invite you to reach out to us with questions that you have, with stories and narratives that you have, because that information is so critically vital for us to advocate on your behalf. So thank you again, and I look forward to keeping in touch with all of you going forward.
Now, I'd like to take the opportunity to thank the panelists for lending your expertise and joining us this evening. And more importantly, I want to thank each one of you for showing up here and taking the time to join us this evening. And for people who have not been able to join us live, please let them know that there will be a recording of this event available on the ASHA website. Guys, as a fellow medical SLP, I can't begin to thank you enough. I can't begin to recognize and acknowledge everything that you do every day. On the front lines, you're making risk assessments and making very, very hard decisions about patient care and your own safety and the safety of your family every single day. You prioritize your patients over yourselves almost every day. And I can't imagine the toll it's taking on you, especially during the pandemic. We consider it a privilege to partner with you in service delivery. Your safety and that of your patients is extremely important to us. And I want to thank you for trusting us, trusting ASHA to advocate on your behalf. It's not a privilege that we take lightly. I know that we haven't had time to respond to all of your questions and concerns, so please take advantage of the ASHA contact information that we have shared on the slides. And stay in touch. We want to hear about your challenges. We also want to hear about the highlights. You are making a difference by every day when you go into work. You're changing patients' lives, and we are here to help facilitate that. Thank you again, and stay safe out there. Bye-bye.